that misinformation or is making a conscious effort to deceive you, your differential now is twofold. What are the two top choices for you, choice A and choice B? And yes, it's two of the four things that you just told me.
Somatic and fictitious, or somatic and... You said we take everything that they say for truth, right?
Oh yeah, there's no evidence that the patient is providing misinformation or is making a conscious effort to deceive you, which is always our baseline.
Somatic and conversion?
Yeah, those are the two, right? And here, you're only going to allow the content, or you only have to allow the content of the case vignette, the patient's report, and the clinical setting to guide you as to whether or not A or B is the single best answer. If you're dealing with voluntary, motor, and or sensory function, in this case deficit, it's going to be called conversion disorder. Everything else is called somatic symptom disorder. So the general idea is that conversion disorder is nothing more than a subset of somatic symptom disorder when the somatic symptom focuses or localizes to voluntary, motor, or sensory function. Okay? That's your two-part differential. For now, let's give George Costanza the benefit of the doubt. Let's rewrite the script. Let's tweak it. That he's not providing misinformation. And upon our providing a physical and neurological assessment, we don't or we can't find an underlying organic pathology. Would this be somatic symptom disorder or would this be conversion, and why? What's his deficit? What's his chief complaint?
Like his limping leg.
Is that motor or sensory? So what's the single best answer?
Conversion.
Perfect. Right. Unfortunately, number one, unfortunately, physicians, clinicians aren't always right. And new evidence often presents itself, albeit not in the initial clinical encounter. That's life as a doctor. And days later, weeks later, we uncover that part of the script that reveals that George Costanza was voluntarily providing us misinformation. And all of a sudden, our initial or provisional diagnosis of conversion disorder now must be reevaluated. What is our two-part differential? What are the two other conditions now that we must consider?
Fictitious and malingering.
Okay. And the differentiation of factitious versus malingering has everything to do with motivation, otherwise known as gain. If the motivation is a conscious effort, we're going to call that malingering. If it is an unconscious motivation, we're going to call that factitious. Right? As a general practice, it is always, when we're in this column, right, when we're thinking that it's either one or the other, we always default to factitious disorder. When there is no evidence as to what might be motivating our patient, we then say that it must be unconscious motivation and therefore factitious disorder. But similarly, when a week, a month later, evidence emerges, workman's compensation papers, a lawsuit for which now you're subpoenaed, and there does seem to be a conscious component to their motivation, external gain, external rewards, we would flip and say it's malingering. What is your final answer as to what ails George Costanza in the butter shave?
Malingering.
And what is his motivation?
Work benefits?
Right. But do you see the way like the 2 or 3 step process gets you to that single best answer? If you just keep to those same 3 steps and don't jump to what the DSM or how we teach you basically how to take tests, forget all that. Just apply those 3 sequential steps. You'll never get that shelf question wrong, and more importantly, you'll never get your patient's diagnosis wrong, and therefore you will never wrongfully implement a treatment plan.
You made a clear differentiation between somatic and conversion, and so you said somatic conversion was musculoskeletal.
Conversion is motor or sensory.
Motor or sensory.
Yeah, that's it.
And then somatic is just
Everything else.
Okay.
Everything else. GI, pulmonary, cardiac, you name it.
Okay.
Other observations, George Costanza, or questions pertaining to how to work up and evaluate medically unexplained physical symptoms. Other observations, characters other than George?
Kramer was a funny guy.
What's going on with Kramer?
He was like using butter as like shaving cream, like throughout the episode. And yeah, just like continued to do it more for everything.
What's going on there? Well, and let me just start off by saying the real answer is nothing. I mean, sunburns aside, or his conflict with Newman aside, if it doesn't result, any behavior doesn't result in clinically significant distress or impairment in some functioning, the psychiatrist says completely normal, right? Culturally sanctioned. But in this case, let's say that there is clinical significance, and then we have this character presenting to us for help. Now, what are you thinking?
I think he's showing like a sense of ADHD here.
How so?
He's just very like restless, and like you said yesterday, like I think about the id. I think he's like taken apart with that. He's just constantly doing childish activities and just trying to satisfy his every like immediate need. And I just think he's constantly doing things, so it's giving ADHD.
It's only a differential diagnosis. So, put words in your mouth. I'm hearing impulsivity. Anybody here a Seinfeld fan? I mean, because often, and again, I'm going to make the clinical parallel to real life medicine. We do take developmental and we do take past psychiatric history into account. Is this a pervasive pattern of behavior of this character, or is this person a completely quote-unquote different person up until this episode? Now we're seeing new onset behavior. Anybody have an idea?
It's kind of like this.
Yeah. Oh, yeah. Nine consecutive seasons of this, yeah. Which covers several years. So there's either a chronic condition or it's a personality disorder, right? And chronic condition also includes substance use. Now, I'm not going to have people go back and, I mean, I should, but I'm not going to have people go back and watch all 9 seasons. But you're going to have to take it from the former treating psychiatrist. This is his medical record, and we've seen this as a pervasive pattern of behavior that is chronic over time. Other ideas in terms of differential diagnosis?
I guess I was thinking along the lines of like personality disorders, maybe like history on it.
So what, removing this from this being character-based or character-centric, what is the defining and cardinal feature of histrionic personality disorder? Yeah. The individual has either must be the center of attention or endures not being the center of attention with significant distress and anxiety. It's always about them. And even in the midst of a conversation, you'll notice that they always start their sentence with I. Is that what's going on here? And by the way, for purposes of studying, for your shelf exam, if you just remember that cardinal feature, you could then look at the diagnostic criteria and they morph into just examples of that cardinal feature. It's so much easier to remember what histrionic personality then looks like. I mean, you review those diagnostic criteria and each will register as a mere example. Just remember that cardinal feature. You can't miss this on a shelf exam.
So how would you differentiate this from narcissistic?
Yeah. The narcissist believes they are special. So they have a grandiose sense of self, and therefore they believe they are special. And if you really want to prolong that sentence, they also believe that others only as special as they can understand them. Right? That is not histrionic. Right? So it's the grandiosity, not the need to be the center of attention.
Like
Jerry, what do you think is going on with Jerry?
he's narcissistic.
You think he has narcissistic traits?
Definitely.
Yeah? Needs to be the center of attention and believes he's special, can only be understood by others as special as he is.
Also, I think he's like very like delusionally jealous for no reason.
Where do you are you picking up the jealousy in this episode, or is
Yes.
it what scene?
Because not sure what his name is, but he got like he's like, oh, I warmed up the crowd, or he's like stealing my girls, or something that he's been there before, so he thinks the entire world revolves around him.
Interesting. It's probably worth, and You can definitely see this on a shelf exam. It's critically important, though, in clinical practice. There are about 5 very consistent things that a clinician must investigate and rule in, validate, to diagnose any personality disorder, right? What are they? Whether we're talking about narcissistic versus histrionic, we could flip the cluster C, something like obsessive compulsive personality, even cluster A, schizoid personality disorder. All of them have about 5, maybe even 6 things in common, and it's very important to know them because, especially when we're discussing cases, you don't want to repeat the same 6 things over and over again. So we should state them now and then just make sure we understand it applies to all of the above when it comes to assessing for a personality disorder. Name me those 6.
It's like stable and long-lasting.
Right? So that's number 1. We use the word stable, so it's enduring over time.
I think one of them is like insight or like awareness into what they know about it.
That's not a required criterion.
Pervasive amongst like all areas of function.
Yeah. So cross-sectionally, it must extend over several areas of functioning. So if you are the way you are as a student, for better or for worse, if outside of school you are a quote-unquote different person, I cannot take the traits that I observe and even begin to discuss, not that I would anyway, but begin to discuss a personality disorder or a personality in general, right? So those 2 are critical to understanding, right? Enduring/stable, as well as cross-sectionally pervasive across multiple settings. I think we have about 4 more.
Distressing or impairing.
Yeah, right. Please, the prior nosology of diagnosing these on what was called Axis 2 led many people to believe that they're less important, they're less clinically impairing. No, they have the same exact bullet point in each of these conditions that depression, anxiety disorders, and other conditions have. They must be clinically significant. They must result in clinically significant distress or impairment in functioning like any other mental health condition. 3.
Substance.
Right? If you're intoxicated, alcohol tends to accentuate personality traits for better or for worse. It would be just blatantly wrong for a clinician to render medical opinion or judgment under acute intoxication or just active substance use. So, yes, and that goes for every other health or mental health condition, right? I would need to investigate and rule out, for an example, a substance-induced depressive disorder prior to diagnosing major depression. The same holds true here. Right? Is that 4? Did I count correctly? 4?
I have a quick question about their point with causing distress. So I thought like certain personality disorders like schizoid or like OCPD, don't they not kind of cause
They do.
distress?
No, they do, by definition.
Okay.
Oh, yeah. Mm-hmm.
It could also be the impairment, right, in addition to distress that gets in that.
Yeah.
Yeah.
Oh, yeah. Impaired functioning, sure. Now, thank you for bringing that up. Schizoid personality is a great example because it does show up in shelf exams. Perhaps due to a lack of insight, individuals with schizoid personality may not self-refer. And that's a little bit of a hint when you read a shelf question because a third person, might actually make the referral. Board of Health, because of the neglect of their property, because of that physical and emotional distance that they desire. So it's still impairing, and it still may be distressful. And that cuts across every one of these 10 conditions. I think we have 2 more.
Not due to a medical condition.
Okay. Like any other health or mental health condition, an underlying medical condition must be investigated and ruled out. Right. I think one of the things that you'll see very often on shelf exams is somebody who presents with new onset antisocial traits. Sometimes the question writer will just kind of spoon feed you and make it late onset, which should lead any clinician to be suspicious. And then you have a biopsy. Unfortunately, it's usually post-mortem that shows inclusion bodies with a biopsy taken from the frontal lobe. Right. So that is not new onset antisocial personality disorder. What do the inclusion bodies rule in?
Lewy body images?
inclusion bodies, and new onset antisocial behavior.
Frontotemporal.
More specific. What infiltrative disease? Somebody look it up. Anyone? Inclusion bodies, new onset antisocial traits.
The characteristics.
Now, what's the single best answer? What's the underlying medical condition? As a predilection for the frontal lobe.
Dementia?
It could progress, a rapidly progressive dementia, but that dementia will also be due to what etiology, what infiltrative disease? Neurologic / medical condition. Inclusion bodies, frontal lobes, not coming up?
BPD?
Disease?
Yeah. Yeah. Comes up on exams all the time. Now you're not going to miss it. I think we have one more. I think we're at 6 of 6.
Mention medical history. Medical history.
Medical history is 1. That's number 5. The 6 is another mental disorder. Okay. Mental health conditions, depression, bipolar, schizophrenia, might result in a change in personality. And you would not diagnose personality disorder in someone that has those traits due to their overriding mental health condition, like bipolar. Those are the 6. They apply to every single personality disorder. All right. Final observations. Seinfeld. The butter shave.
That guy that found Kramer's buttery burnt scent, like, enticing. Like, imagine him on a turkey. A little weird.
Yep. So, differential here?
Delusional disorder.
It starts out, if he's got this, intrusive thought that is not reality based, that certainly could be defined as a delusion, and we'd have to then investigate the potential theme. And very similar, is it due to a larger mental health condition like schizophrenia? That's not the case here. Again, having watched 9 seasons more than once, probably not, or rather definitively not. What is pica?
Repeated ingestion of non-nutritive substances.
Yeah. Now, I don't know another human being is non-nutritive. It's certainly taboo and illegal, and mentally ill. It's not captured in a way in the DSM that you'd think. Right? I don't know, maybe an unspecified eating disorder, if not pica. But I think we're splitting hairs. I think if this were an individual who presented to clinical practice with need for help, there's definitely something to examine here. I'm wondering if we wouldn't be in the feeding and eating disorders chapter of the DSM. It certainly would be part of our differential. The feeding and eating disorders chapter of the DSM has 6 conditions, including pica, so you have 1. The 6, I think, can be categorized, especially for study purposes, as those that are common versus relatively uncommon. And I'm talking about within the eating disorders, right? Not necessarily in terms of real demographics. So if an individual has an eating disorder, then we say, well, the 3 are relatively common, and then there are 3 that are not. What are the 3 that are relatively common?
Anorexia nervosa.
Number 1.
Bulimia nervosa.
2.
And binge eating.
3. Okay. Unfortunately, there's a 50-50 chance that a single best answer on a shelf can include a less common, so you're going to have to study them as much as you would the more common. And in addition to pica, what are the remaining 2?
ARFID, avoidant restrictive food intake disorder.
Rumination.
A rumination disorder, right? All right, I wanted to make sure we just listed them, write them down, definitely commit some study time to them in preparing for your shelf. Any questions, you could always ask us or any of the faculty. But I don't want to get into the actual specifics here. If you remind me later, there's a nice algorithm that I created. I can post on Instagram for you to help study and guide you through them. It's relatively straightforward. And if we have time later, too, you can remind me about the quote-unquote the cards. It'll help you study. It's a study aid. But if we have time this afternoon, I can definitely show you that as well. All right, this is a great place to stop.